Good morning, friends. Well, today I welcome you to the session on ferric carboxymaltose injection. Before going on to ferric carboxymaltose, we are going to talk about the properties of an ideal parenteral iron. Properties of the ideal parenteral iron, what is the type of the iron which is used for the preparing an ideal parenteral iron? Well, it should be type 1, which is robust in size. Its molecular weight needs to be more than 1100 kilodalton. The complex needs to be stable. Its half-life needs to be long. pH, it should be neutral to the body fluid. It should be isotonic to our body fluid. It should have low antigenicity. Henceforth, no test dose is required. Time for administration of this injection should be short, and it should be possible to deliver maximum dose in this short interval of time. We have iron sucrose and we have got ferric carboxymaltose injection. If we see iron sucrose, it is a type 2 semi-robust iron, whereas ferric carboxymaltose is a type 1 robust, which resembles the properties of an ideal parenteral iron. Now, the molecular weight of iron sucrose is 34 to 60 kilodaltons, whereas ferric carboxymaltose is 150 kilodaltons. Henceforth, it is again resembling an ideal parenteral iron. The complex of ferric carboxymaltose is highly stable, whereas iron sucrose is moderately stable. Half-life of ferric carboxymaltose is 16 hours in comparison to iron sucrose, which is just of 6 hours. Hence, you can see all these points are in favor of ferric carboxymaltose injection. Now, considering the pH for ferric carboxymaltose is near neutral, that is resembles again, or it matches the pH of a normal body fluid, which is approximately 7.4, whereas of iron sucrose is slightly on the higher side. Ferric carboxymaltose injection is isotonic, whereas iron sucrose is highly osmotic. Then antigenicity for both the injections is low, and it is safe to be given to human dose without a test dose. Injection for time for injection, if you see for parenteral iron, ferric carboxymaltose is 15 minutes for 1000 milligrams, which means approximately 10 times more the same amount of drug can be given safely to the patient when we compare it with iron sucrose. Maximum dose for iron sucrose is 600 milligrams per week, whereas ferric carboxymaltose injection has 1000 milligram infusion per week. So definitely we see in these properties that ferric carboxymaltose injection is more safer and more efficacious as compared to other available parenteral iron. Well, this molecule was approved by UK MHRA in July 2007. FCM is approved in 38 countries, of which 29 are in Europe. In India, it was approved by DCGI in February 2011. Now, this is the latest parenteral iron, which is closest to the ideal parenteral iron. So, let us talk about the different properties, how this carboxymaltose moiety helps this injection in binding it. Now, considering the structure of ferric carboxymaltose injection, you can see all the brownish orange which is there is the iron, which is bound by the carboxymaltose moiety or the carbohydrate moiety. The purpose of this carbohydrate moiety or carboxymaltose is to bind the iron together. It functions as a glue. So now let's read what's written on the slide. Ferric carboxymaltose injection contains iron in the stable ferric form as a complex tightly bound within a carbohydrate polymer. Due to the stability of the complex, it does not release ionic iron under physiological conditions. The iron hydroxy core with its carbohydrate shell is taken up by the macrophages and enters the lysosomes, where ferric can be converted into ferrous as required. Now here you can see the ferric or the iron 3 hydroxide core inside a carbohydrate shell is taken up by the macrophages, and this ferric is converted to ferrous. Now this ferrous is released by the divalent metal transporter DMT1 and then by ferroportin and finally taken up by transferrin after oxidation by ceruloplasmin. Now this is the transport form of your iron, that is transferrin. Now what is the utilization by the red blood cells? When iron FCM is given or is administered to a patient with iron deficiency anemia, FCM is distributed in the liver and spleen and taken up predominantly by the bone marrow from within 60 minutes after administration. And within 2 to 3 weeks of FCM administration, iron utilization rates were 91 to 99% in IDP patients, that is iron deficient patients, and 61 to 84% in patients with functional iron deficiency. What were the release rates? So here we are comparing the degradation kinetics of different available iron forms. So just the conclusions I would like to talk on just now. The release rate of iron is inversely proportional to the molecular weight or the size of the complex. So if you see here in the graph, it's very much evident that ferric carboxymaltose, because of its high weight, has least release of iron. Then the rate of iron release is reflected in its side effect profile. So ferric carboxymaltose, again, because of less release of iron, its side effect profile is better. That means there are lesser side effects when ferric carboxymaltose injection is administered to the patient. So iron release rate from FCM is close to seen with the iron dextran. So this should be a query in your mind: when iron dextran is better, then why not give iron dextran instead of ferric carboxymaltose? Well, this we will talk about in detail. Well, the iron dextran, when doctors were giving this molecule, there were many anaphylactic reactions and allergic reactions. The allergic reactions were due to the iron, the dextran which was present in the iron. So it had to be banned, and well, very few doctors still prefer to give iron dextran. Now, what is the composition of our ferric carboxymaltose, that is Orofer FCM? Well, each ml contains ferric carboxymaltose equivalent to elemental iron 50 milligrams with the water for injection IP quantum status, and the presentation is in the form of a vial of 10 ml which contains 500 milligrams of ferric carboxymaltose. Well, the storage, yes, you need to store in the original package. Do not store above 30 degrees. Do not refrigerate or freeze. These are the important points what we need to consider about its storage, its presentation, and its composition. Now, dosing, as we all are aware of, it is to be the cumulative iron deficit has to be calculated by the Ganzoni formula, which it states that cumulative iron deficit in milligrams equals to your body weight in kilograms into target hemoglobin minus actual hemoglobin in grams per deciliter into the product of with 2.4 plus adding iron storage depot, that is 500 milligrams. Now we use a simpler regime as used in Ferric study in gastroenterology 2011. Now this, according to this regime, we are taking two parameters. First is the hemoglobin and second is your body weight, and accordingly we decide the dosing schedule of the patient. If the hemoglobin is 10 or more and the body weight is between 35 to 70 kilograms, then 1000 milligrams of injection has to be given in a week. When the hemoglobin is 10 and more and the body weight is more than 70 kilograms, then you need to give 1500 milligrams. This can be divided into 2 weeks. First week you give 1000 milligrams and in the following you give 500 milligrams. When the hemoglobin is less than 10 grams per deciliter and the body weight is between 35 to 70 kilograms, then 1500 milligrams is advised. When the hemoglobin is 10 and the body weight is more than or equal to 70 kilograms, then 2000 milligrams is advised. Now this 2000 has to be divided into 2 weeks. First week again you give 1000 milligrams and the second week again you infuse 1000 milligram. Note that a cumulative iron dose of 500 milligrams should not be exceeded for patients with body weight less than 35 kilograms. So just doing a recap once again, we use simple regime as used in the Ferric study of gastroenterology in 2011. It takes two parameters into consideration. First is hemoglobin and second is the body weight. When hemoglobin is 10 or more, then 1000 milligrams is to be infused in patients weighing 35 to 70 and patients weighing 70 and more, 1500 milligrams. If hemoglobin levels are less than 10, then 1500 milligrams for patients weighing 35 to 70 and 2000 milligrams for patients weighing more than 70 kilograms. For all patients who have body weight less than 35, the ideal cumulative iron dose should be not more than 500 milligrams. Now this iron for injection, FCM, can be given in undiluted forms at the rate of 100 milligrams per minute IV for up to 500 milligrams. Thereafter, between 500 to 1000 milligrams for 15 minutes. In case of drip infusion, ferric carboxymaltose injection must be diluted only in sterile 0.9% sodium chloride solution. For 200 to 500 milligrams, 100 ml of normal saline and minimum time of administration should be 6 minutes. For 500 to 1000 milligrams, 250 ml for 15 minutes. The speed for infusion is very critical because it releases the iron, hence you can have allergic reactions due to faster transfusion or slow transfusion. Now, what is the commonly encountered adverse effects when we are giving this injection? Well, mostly they are from the nervous system. They are the headaches, 3.3%. Then of course we have the gastrointestinal, like the nausea, abdominal pain, constipation, diarrhea, skin, you have the rashes, you have injection site reactions, you have transient blood phosphorus levels are decreased, and alanine aminotransferases are increased. So these are the common side effects which are encountered when we are giving ferric carboxymaltose injection. Now, what are the specialities and what is the application we need to discuss? Well, in nephrology, we can give in the CKD patients. Well, in gynecology, yes, PPA and the AUB. PPA stands for postpartum anemia and abnormal uterine bleeding. Orthopedics, perioperative, before the surgery, knee surgeries, hip surgeries. In IDA, in heart failure, of course, in IBS, that is irritable bowel syndrome, in gastroenterology, and it can be also be given safely in cancer patients who have got iron deficiency anemia. What are the contraindications? As we know the indications, we should have a fair bit of knowledge about the contraindications. Known hypersensitivity to ferric carboxymaltose injection or to any of its excipients. Second, anemia not attributed to iron deficiency anemia. Then evidence of iron overload or disturbances in utilization of iron in pregnancy in first trimester, and in children below 14 years. Now pregnancy, it is contraindicated in first trimester. Second and third trimester, careful risk versus the benefit has to be evaluated, and then only it can be given to the population. Iron from FCM can cross the placental barrier. It is less than 1% is secreted in the breast milk. Children's, it is not being studied and it is not contraindicated. In patients with hepatic dysfunction, caution, iron assessment should be done prior to giving this ferric carboxymaltose. In acute or chronic infections like asthma, eczema or atopic allergies, you have to use ferric carboxymaltose injection with caution. Now, what are the benefits of this high dose iron therapy? First are the fewer clinic visits, improved patient compliance, reduction of blood transfusions, preservation of the venous axis. Well, definitely these are the important points what will help a doctor from switching over to other forms of iron, parenteral irons. Now, definitely the most important is the savings for the patient, which we need to highlight. Total cost of the disposables will be less, total monitoring cost will be less, true hospital costs will be less, total productivity loss will be less, total traveling cost will be less.